afternoon, dear friends, and to all the participants who have joined in this webinar. So the topic for today's webinar is critical care nutrition. As you all know that malnutrition is prevalent in intensive care units throughout the world, and critically ill patients receive only 40 to 50% of their prescribed nutritional requirements. So the inadequate nutrition is associated with increased complications, prolonged hospital stay, as well as increased morbidity. So to discuss in detail the nutrition in critically ill patients and about PEPA protocols, that is protein energy provision via the enteral route feeding, I would invite our esteemed speaker, Mrs. Anita Jetana, who is a chief dietitian in the Apollo Hospital, New Delhi. So to know her more, Mrs. Anita, she is having more than 35 years of experience in the field of nutrition with special interest in critical care. She has been awarded a Scroll of Honor of Professional Achievements in Lady Irwin College. She was also awarded for outstanding contribution to the field of dietetics. Mrs. Jetana has already presented more than 50 scientific papers at different national platforms. She has been involved with various research projects as well. She had also participated in FICCI and International Hospital Management Awards. Mrs. Jetana is also involved with Directorate of Education in the meal program. So may I invite Mrs. Anita Jetana. Over to you, madam.
Good afternoon. So you set the ball rolling very well. Sunita, thank you. And thank you to Nestle for inviting me here. I think we talk a lot about malnutrition and critical care. I don't know, I think it's been centuries really since we've been talking it. In fact, malnutrition in hospital, of course, as you said, has been undiagnosed. And we've been talking and discussing over it since years, really years. In fact, Florence Nightingale, I think, mentioned it as back as 1859 when she said that, hospitalized soldiers starving among plenty. And then also by Charles Butterworth in 1974 when he spoke about the skeletons in the hospital closet. So it's as old as that. And we're still discussing this problem. We've come a long way. We've seen very good results. But I think we still have some unanswered questions and still a long way to go. So we've reached a long way, but still a little journey ahead, which we must take together. So you just mentioned, yes, prevalence of malnutrition is huge. It's 30 to 55% of hospital patients which are malnourished on admissions. So in India, you would know the reasons. Obviously, it's because of poverty, it's food fads, and people don't want to eat the right food. In fact, not only in critical care, I'm talking about a study that we did in our hospital, and we found that 90% of our patients were not taking adequate protein. They were just taking a katori of that. So when they're already malnourished, when they come to you and, during the hospital stay, they get worse. For this, we as a team are responsible. So 33% of severely malnourished patients and 38% of well-nourished patients experience a decline. Now, this is something which we should absolutely avoid. Is it very simple? No, because as we go down, you will realize that it's not as simple as we think of just giving calorie proteins. It plays a huge role in trying to get the right things. It's a very fine balancing act. So many patients continue to lose after discharge because we don't spend ample time giving them a detailed diet summaries or, making a diet chart as tailor-made to their requirements, to their financials. So it has to be actually tailor-made and not just giving a handout. And patients lose increased risk of readmission. So that we know. So patients who don't do well at home, then obviously will come with maybe wounds gaping or things which are problematic, and they have to have another problem. So malnutrition in critical care, as I said, why does it happen? We think we've given them good nutrition, but we still have problems. In critical care, the metabolism increases by 25 to 50%. So you can imagine a person who's not eating adequately, and then you got a huge gap that you must fulfill with 25 to 50% rate increase. In presence of sepsis, metabolism exceeds even 50%. There is a loss of protein up to 10 to 15%, and there is a loss weight. So we've seen this in our long stay patients that they lose weight despite giving them real good nutrition. In fact, we did a little study in long stay patients and we found that the needs were much higher than even the ICU, where they come for short stay and we had to really build them up and they were losing weight. So this is for long stay patients. So this is again assessment of malnutrition and enteral nutrition practices in critically ill. This was a study, and you can see the study population was of 200 the adult ICU patients. Now just look at the figures. 45%, 48.5%, and 9% of patients had mild, moderate, and severe. So most, I would say, would fall into the category of mild and moderates. Only 9% had severe. Common cause was non-attainment of daily feeding goals due to feed procurement and feeds being held for procedures. We all know in our hospital, we are all working there, how many times you'll find the morning slips that you get will be NBM. Fasting for procedures, fasting for any small investigations. There are ERAS protocols which says you can feed up to 2 hours before in the morning with the carbohydrate loading, but I don't think many hospitals are practicing that now. So patient may be fasting from 12 o'clock midnight and you'll find that surgery is postponed or even cancelled sometimes and you've lost 1 day. Patients with malnutrition obviously have a higher risk of mortality. There is no two doubts or questions about that. So 2 simple questions will tell you, and I think most of the hospitals are NABH and JCI accredited. So we are all doing nutritional screening as assessments, but 2 simple questions is all that you need to do even in an OPD scenario. Energy intake and weight loss. That's it. So 2 simple things and you'll be able to say, is the patient into moderate or severe malnutrition? And there are absolute clear guidelines on this. You just have to pick this up and say where that patient falls. If its intake is less than 75% for 7 days, so if a patient comes to in the OPD and says, I've not eaten well, he is into the acute disease with a non-severe moderate. And if he's not taken less than 50% for 5 days, then he's in the severe risk. So you can just see there are categories. So all you have to know is which category is he falling on, and you'll know, is he acute, is he chronic, or is he in the starvation mode? Simple question of 1 to 2% in 1 week. Can you imagine how much it is? Quick division of 60 kg weight. So 10% is 6 and 1% is 0.6. So if he's losing even 1 kg in 1 week, something to say, yes, we have to give a closer look to it. And there are again guidelines and say that 2% in 1 week, 5% in 1 month, more than 5% in 1 month. So there are very, very clear guidelines which we sort of need to refer to. And that's all. And you'll be able to know which category is he falling on. So metabolic response, I wish that the reverse was right, really. Because when we are doing obesity and giving diet charts, people go on starvation diets. So what happens is their RE goes down, right? So it becomes they start guarding their weight. And that's when you start eating, then you put on. So that's another problem. But in stress, see where the RE is doubly increased, and look at gluconeogenesis, 3 times more increased, the blood glucose levels. So you suddenly find patients in ICU, where the parameters go haywire. And most patients in ICU would need insulin. And even though they were oral medications earlier, and once they get back to the ward, you can again taper them to oral. But during ICU stay, it has to be a good tight control. And you can see proteolysis is 3 times more, and obviously which will lead to urine nitrogen losses. So look at all these things which can create huge problems to a patient who is in ICU. Metabolic response to trauma, we have the pro-inflammatory cytokines, the interferon, the tumor necrosis factor, the growth factors which are secreted by the cells of the immune system. Then we have the counter-regulatory hormones and the catecholamines. So these are the epinephrines and dopamine which are released from the adrenal glands. So this is like a fight or win situation, and these regulate your heartbeats and your breathing rates. So these all are increased during this catabolic stage under stress. You just heard Sunita say what are the consequences. Huge increase in length of hospital stay, obviously increasing treatment costs, loss of weight, all adding to alterations in cardiac function, compromised wound healing, reduction in glomerular filtration. So all the organs and the multiple organ failure starts happening if you don't address this problem. And obviously impaired immunity. You've seen it in your everyday life that people who eat well, recover fast, even from a surgery like a bypass or anything else, they get back the moments they are eating better. And the people who are crying and not eating and not compliant about the food, you'll find them there. And people in long stay and neuro problems will have bed sores, which will create another problem for you. And then there's more protein and more requirements are higher for those patients. So should all ICU patients be treated equally? No. They can't be one yardstick. It has to be, you'll have a malnourished patient and you'll have an obese person. So the calorie goals, the nutrition goals will be handled differently. But having said that, don't think the obese person who looks so well nourished won't have micronutrient deficiencies. He will have micronutrient deficiencies, though there are papers which says that in vitamin D it's something like 70%, and the albumin levels are low in about 30 to 40%, even though they're obese. So you just have to, and all the B complex vitamins also, because most of these people are obviously eating junk foods and not eating a well-balanced diet. So all will have to be absolutely tailor-made feeds according to the patient. So just a quick screening as we discussed. Don't let it go undetected, and definitely do a good assessment. So we definitely need to do, and there are a lot of forms, whichever you think you can take into your hospital, but make sure that you do it. So there are so many of them. See which one is possible for you. Of course, doing must is quite popular, and most of them are doing it. But if you think you can't do it and you've not adopted it so well, you can start with a mini nutritional assessment, or you can do a malnutrition screening tool, which is very simple. Otherwise, do a SGA, which is also very doable with a few questions. Of course, the hospitals have moved on to Nutri-Score, and we are doing the NRS 2002, which is a little time consuming, but the need of the hour. So that's, we go on increasing to better things as we move in critical care. SG, as I said, there's a scoring system, very simple to do, must do by for all, if in case you're not doing it so far. This is the NRS 2002 guidelines, SPEN guidelines. There is a very simple scoring system which says mild score, moderate, and a severe score. Weight loss of more than 5% in 3 months. And if your food intake, as we discussed earlier, 50 to 75%. So all this is there for you to take out. It's there on the Google. All you need to do is take out that score. Add 1 in case that person is 70 or a geriatric patient. So you'll have to add 1 to his score to know where his scores are. Nutri-Score, some hospitals are doing it, especially for ICU patients. It's a good thing to do, but it is you need doctor's help. The dietitians will definitely need a doctor's help because it takes the Apache score and the SOFA score. So this gives you a very good outline to where that patient is malnourished or not. And it also takes the ILS, interleukin 6. And there is again another very nice system of scoring, which says high-risk patient with either an NRS score of more than 5 or a Nutri-Score more than 5 without interleukin 6. So you know that he's on the high risk. So if you've done that, you will know that he will need more focused attention than a person who's on a low to moderate risk patient. But having said that, doesn't mean you ignore his nutrition. So these patients obviously, you just do a calculation and you find that they're eating, and reassess them, keep having a relook at them. We have a system in our hospital where we have to reassess our patients every week. So you know that they're not sliding down just because they were on a low or moderate risk earlier. So you still keep looking at them. So these are the guidelines: early nutrition, early EM. We don't have to wait for guts. I just want to re-emphasize within 24 to 48 hours is the guidelines. Start early. So your decision making becomes very clear. You assess the patient's nutrition therapy needed. Obviously, you have a GI tract which is functional. You will go into enteral nutrition, no contraindications. You do oral, you do supplementation at bedside. If he's eating well, you just assess, is he reaching his goals or not? One day maybe he's not eaten, but if on the second day, third day, you find on your rounds his oral intake is not picking up, please pick up the phone and tell the consultant, sir, I think we need to do a tube feeding for this little patient. And if contraindications is there, we know parenteral nutrition is the way forward. So don't let them go into starvation just because you think, oh, he's going to pick up in a day or two. Don't give him more than that. So we know all that, okay? So I'm not going to do that. But if you do peripheral venous, in case it's there for a short time, then you can do peripheral. But you think you're going to do parenteral nutrition for a longer period of time, then you will do central venous system. And the earlier guidelines were, if the gut works, use it. But the new one says, if it's not there, make it work. So how do we make it work? By pushing in too much of fluids? No. And if you don't make it work, see what's going to happen. You can just see the entire villi has flattened up and there is going to be a translocation. So this will create problems and the multiple organ failure if you don't. So that's why doing enteral nutrition, even if though it's tropic feeds, please try and achieve that. It's important. So we know enteral nutrition maintains gut function and integrity. It stimulates GI contractibility, supports gut and mucosal associated lymphoid tissues, and obviously the gut microbiota is there. So we definitely will take this as the first course. I don't think anybody is using this gold standard of IC measurements. I think only 0.5% hospitals all across the world are doing. Predictive equations are too time consuming. Simple things like 25 to 30% is the thumb rule. Easy to do. But the only question is, what kg will you take? So if you have a person who definitely has even ascites, then you will do minus 2.2 if he has got minimal. And if he has severe, then you will also have to minus 14 kg from his overweight. And if he's got edema, then you can minus 1 kilo. And then if he's got severe edema, then it has to up to 10. So you have to see where and then say how much to calculate for that. Otherwise, your calories could be higher or lower predictions if you don't do it right. So we says use a simple method. Now consider hypocaloric feeding in critically ill obese. I just want to re-emphasize that. What kg do you take for a person who's obese? You start with either the 60 to 70% of the target calorie requirements, or if you got the actual body weight, just to 11 to 14 calories per kg. So that's where your calculations sometimes go haywire. And 22 to 25 if you do the either body weight. So instead of doing 25, you come down to 22 if his BMI is more than 30. So just remember this. And the same thing stands true for a malnourished patient. Initiate at 50% of the requirements for the first 2 days. You will have doctors pushing you, give him a high calorie. If you're not able to wean him off, please tell them, I'm going to take a couple of days to reach there. Or the calculation is simple. Start here and reach your calorie goal. Don't stay here, but start here. Protein requirements again will be different. 1.2 to 2 for a BMI less than 30. 2 if his BMI is 30 to 40. And 2.5 ideal body weight. So we are talking of ideal body weight here if he's more than 40. Target fluids 30 to 35 ml and 25 to 30 for underweight. So you've got your calories, you've got your proteins, you've got your fluids. So you know where you're going to reach and where you're going to start from, and your prescription is ready. So, okay, now, micronutrients are very, very important. And I before all these formulas were available or the nutrition supplements were there, we also used to just take kitchen feeds and put in the oil and put in the sugar till we didn't have a choice. But today you have a choice and you realize that they're so important to get all this right. Because if there are deficiencies or your zinc, magnesium, potassium, they all play a very, very important role, which is not going to happen in a kitchen-based feeds. So make sure that, all the micronutrients are addressed when you are doing your tube feeding. Phosphates requirements you have to see, and early enteral nutrition, again supported with a lot of science that you can do, and you don't have to wait for bowel sounds as evidence of bowel function. In fact, they say take away the stethoscope from the doctors when they are in the ICU, but that's in the lighter vein. And there's another study which says that early enteral nutrition versus delayed enteral nutrition definitely has a lot of support for using and initiating much faster. So how much should we start? We've calculated our calorie goals, but even if you think, oh, he's too sick, you can start even at 10 to 20% of the calories. It's enough to get your visceral blood flow benefit. And of course, to get the entire benefit, you must do on a 50 to 60% of your requirements as soon as possible. Even though you're not reaching 100%, but try and reach here much faster. Okay, so the lowest mortality, of course, was achieved with EN, which provided only 80% of your goal calories. This is important. Tropic feeds, just 10 to 15 ml. That's about 3 teaspoons per hour. That's hardly anything. If the doctor says no, tell him there's more than 4 or 5 liters going through his anastomosis. Nothing will happen. Let me give. It's like a trickle. It's literally a trickle feed, continuous feeds. So just convince them, show them the guidelines, and you'll be able to do it. So even those small volumes also stimulates the peristalsis and prevents bacterial overgrowth, stimulate gastrointestinal hormones, and obviously is less costly and provides substrates to support the intestinal function. So that's just 3 teaspoons in 1 hour. And then keep increasing every 12 hours by 15 ml till 60 ml per hour is achieved. So it will take slowly, but you'll advance and you'll reach your goals. So GRV, I think everybody's been talking about it a lot. We don't have to stop the feeds till it exceeds 500 ml. And that again has to be, if it's 200 to 500, just do bed elevation, start them on erythromycin or start them on the medication and do refeeding of that what you aspirate. Don't throw that out. I don't think many hospitals do that, but that is the guideline. So this is what I was talking about when I said don't start here for a malnourished patient, because patients who have long history of poor caloric intake due to anorexia or maldigestion or malabsorption, and then we aggressively feed him, they are at the risk of a refeeding syndrome. And we see it every time because the doctor is so enthusiastic, oh, we are starting, let's do it. So overfeeding a malnourished patient adds to the physiological burden by increasing the cardiac output, respiration substrates, and interconversions. So overfeeding substrate without sufficient micronutrients can precipitate serious hypothermia, hypophosphatemia, hypomagnesium, and other micronutrition deficiency. So if you said the phosphate requirement is about 0.3 millimoles per kg per day, and what is the way to calculate it? Very simple. If you know the proteins, there's a simple formula, 128 into 14 into grams of protein. You know what is the protein content of your food. And if hypokalemia is persistent, check for magnesium. So, all the micronutrients, as I said, play a very important role. Zinc deficiency is huge in GI losses and diarrhea, so you need to monitor those very well. And of course, analytics is definitely there. So prevention of refeedings ensures starting slowly and then gradually advancing. Tube feeding syndrome, some of you may in your parameters. Tube feeding include azotemia, hyponatremia, and dehydration. When we give a very concentrated feed in small volumes, this normally happens when you have a patient who has a renal problem and you've given just a volume of 500 ml, and yet the doctor writes a prescription of 2000 calories and I want 80 gram proteins, then that's a problem that you will have. So you have to please make sure that you do not give a high renal solute load and a negative fluid balance, which results in dehydration. So be very careful. Don't go greater than 1.5 ml per kg of desirable body weight, which can help this syndrome. So this is the disadvantages. As I said, you will not get the micronutrients. They will, and who's making those feeds every day will change. And if any of you actually made a feed yourself in the kitchen, I did it because I actually wanted to understand when the doctors were pestering me on chicken soup and fish soup. We actually blended it. You know how much went into that tube? Just 2 grams of chicken in the 300 ml volume. We boiled it and we sieved it. Everything was there in the sieve. So nothing went in. And if you actually do a khichdi feed, you blend the dal and the rice, you actually achieve only 3 grams of protein in a 300 ml volume I'm talking about. So if you actually do it, you realize you're not giving a patient nutrition. The only thing which is good is milk. And if you have lactose intolerance because of all those medications that are happening, you're in for another problem. So please just be very careful. A lot of, again, studies, I've just put them all together, which says this microbial and nutritional physical quality of feeds which are bad, the contamination will happen. A lot of studies which says that using just plain kitchen feeds is not going to happen. I still know some hospitals are doing blending roti and dal together. I'm wondering what goes into that. And raw eggs are not allowed because of the salmonella infection. So don't give that raw eggs. So this is another study which was published which says protein in blenderized diet. See where you end up with. So the protein from different size. So for the patient receiving 1.5 liters of feeding per day, this would mean a difference of 51 grams of proteins per day. So it's not going to be achieved till you've added some good supplements to the feeds. Does underfeeding in ICU exist? It does. Some hospitals, as you see, are doing well, who are doing good practices. This is the mean, but I would rather go by these values where the hospitals are not doing because of costs by the management, by the other departments, or by the medical team. So you obviously see that they are much, much lower percentage received than prescribed. So look at your prescriptions. You're not even at 40%. So just convince them that the ICU stay is more expensive than a box. So there's another thing. So to reach those targets, this initiative was taken up, I think, and this new protocol was there, which is volume-based feeding protocol. So when your patients are fasting through the night, you want to pep them up. That's another volume-based. But this protocol is another protocol where you can start early. So what does it say? Volume-based feeding, early enteral nutrition, advanced early, tropical full feeding, and volume-based top. So all have agreed that we need to do this, and volume-based or top-down multi-strategy feeding protocol was another thing which found good results in the medical patients. They didn't see so much of change in surgical patients because they could not advance as fast as the medical patients. So this is the volume-based feeding which has now been there. It was there in 2016. And it was published in the Anesthesia Journal, Critical Intensive Care, and it was done by Dr. Helen, which was based on a 24-hour volume rather than an hourly rate. Initial infusion rate was determined by dividing what you wanted to calculate. You've calculated your volumes. The hourly rate, of course, changed, and it was taken from 8 o'clock and to 8 o'clock the next morning. So the time was definitely noted, and the daily rounds were there and documented by the dietitian. So all these patients were started early with a elemental formula. We all know that doing a peptide-based formula definitely is good. We use it a lot for our diarrhea and a short gut syndrome. But they found that patients in medical care, if you do a semi-elemental formula, do much better. The absorptions are better. So the regurg is not there. And on third day, they could initiate on polymeric food. So the first 2 days, if you do a semi-elemental formula by using tropic feeds, you can use this formula. And of course, they were put on the medications of methochloramide. So that was there. So begin this formula at 10 ml, which is 2 teaspoons as tropic feeds, as we said. Do not monitor gastric residual volume. So this was the study that was conducted in the critical care patients and the recessibility to transition to volume-based feeds the next day. So it was a quick start with semi-elemental, and then within 3 days, a polymeric formula. So then this was there. They were intended for patients who were on vasopressors, regardless of the dose, as long as they were adequately resuscitated. Not suitable for high volume enteral feeding, ruptured day, surgical placed jejunostomy, upper intestinal anastomosis, impending incubation, or risk of refeeding. So on these very selected patients, they did the study and they found a good improvement by 12 to 15% calorie and protein goals or better. So that's a huge amount when you have, gaps where you can't reach. Contraindicated, we all know, when we don't give feeding, recent operations and high NG output, then was the contra. So in conclusion, we assess patients on admission. Important for all the dietitians, initiate early within 24 to 48 hours, take steps as needed to reduce aspirations, and the high-risk patients change the level of infusion. In case required, you can go down to the small gut and elevating the head, which is important, 100% of the patients. And do not use gastric readable volume as part of routine care, and do not stop feeding in case of either diarrhea or if the volume is less. But I'm just going to share a quick study which we did here in our hospital, where we found the poor delivery. We took weights of, we did it on long stay patients, right? And we found people were dipping weight and we were worried. It was like an eye opener to me. Why is it happening? We're giving them such good nutrition. On paper, it showed calorie, proteins, achievements, everything. But we found that, just look, most of them were showing a dip. So we actually studied it. We did it in a high dependency unit. So quickly just show you what we did. We took the age, we took the date of feed, we individualized nutrition therapy plan, and the clinical parameters were taken, highlighting the major failure. So we took what were the major failure modes, taking appropriate corrective measures, sensitization of the respective multidisciplinary medical team. So all this was taken into care, the nursing staff, the patient's nutrition assessment, communication of feed, preparation. So all these steps were taken into consideration. So this was the failure modes that we identified. Delayed assessment by the doctor. He didn't come for maybe 4 hours, 5 hours. He was busy in another ward. Nutritional requirements were inaccurately identified and the nutrition order was not documented. So obviously the sister didn't document it and the dietitian didn't know even of the patient's admission. And you've lost maybe 6, 7 critical hours before you actually started him. She then overlooked the order because she's looking after 5 patients, 6 patients. But ICU, of course, is less. This was another ward, but she still forgot to do the entry. The nutrition order is not received due to server issues. We just had one, right? So it didn't work. It's not working. What do I do? And unless she documents it, the dietitian will not take the order. That's the protocol. So when she finally she plans the diet, the steward in the food section did not follow the composition prescribed. He did what was prepared. He just sent it forward. Section alters the feed composition himself. जो बना हुआ था उसको क्यों देना है? The fuel volume by this section is more or less, they just fill it up. Did they measure it accurately, 50 ml or a 150 ml? Full volume is feed not delivered due to clinical reasons. The sister just keeps it away. Extra volume is thrown away. So you think the feed has gone, but the feed actually didn't reach the patient. So you find all these were bottlenecks when we actually reach the patient. So the delay, under and overestimation, delayed information, and on-time delivery, and giving it to the patient on time. So we found once we addressed all those issues, we found there to be a good improvement between pre-intervention and the post-intervention. The target proteins are better achieved at 97% and your calorie needs by 94%. So just addressing those problems, we came up with a protocol and we found our patients doing much better, especially long-stay patients. So let's recognize malnutrition, start early, avoid disruptions because that we really see, and individualized therapy. Can't be one goal to all. Thank you. Thank you all.
Thank you so much, Mrs. Anita. It was so informative, so elaborate, and you have covered all the areas. What is, prevalence of malnutrition in hospital, assessment of malnutrition, then different nutritional tuning tools, Nutrix score, about nutrition recommendations, micronutrients, macronutrients. So, very, very good. About refeeding, about tube feeding syndrome. So I think all of the participants, they must have gained a lot from your talk. So I request you to stay there for question and answer session at the end. Friends, now we have another session by Mrs. Salome Benjamin. She'll be talking about surgical nutrition. So, as you all know, nutrition management in surgical patients is important to avoid risk of underfeeding during the post-operative phase after major surgery for prevention and treatment of catabolism and malnutrition. So, to discuss in detail the guidelines to cover nutritional aspects of ERA's concept and special nutritional needs of patients undergoing major surgery, I would invite Madam Slomi. So, just to introduce her, so Mrs. Slomi, she is a medical nutritionist presently working as medical nutritionist in Jupiter Hospital, Thane. She was chief medical nutritionist and HOD dietetics at TN Medical College and Nair Hospital from 1981 to 2015. She was chairperson of Registered Dietitian Board of Indian Dietetic Association from 2016 to 2019. She was also the director of Nutrition Academia, Cuddles Foundation from 2016 to 2018. Madam was also vice president and founder member of Association of Diabetes Educator. She was president Indian Dietetic Association Mumbai chapter from 2006 to 2010. Mrs. Slomi has authored, edited, and published, presented many papers, articles, review articles, and she has many chapters in books and reputed journals to her credit. She is a regular speaker and chair at national and international conferences, and we are lucky to have her with us. So I'll request Slomi Madam to join. Over to you, please.
Good afternoon to all. And Anita, thank you for a nice presentation. Congratulations. So we move over to the presentation. My topic today is nutrition in surgery. You all know that it is a very vast topic. So I would not be able to cover all the principles of nutrition in surgery. So I've just chosen one particular aspect to cover up, and that is I will be talking about the brain injury. Either you call it a trauma to brain, traumatic brain injury, in short, brain injury. Yes. So when we look at these patients, I want everybody's attention, because most of the time what happens when we go to see a surgical patient in a surgical ICU or a trauma ward or a recovery, we will just look at the order, the doctor's order or the diagnosis, or sometimes ask the nurse, okay, what are the orders and plan. It is not so. We must look into what does the brain injury involve. It is primary involvement, the mechanical forces, the what force the injury has occurred, and the secondary is insult, whether it has metabolism, biochemical and the metabolic, the other processes involved like hypoxia, hypotension. So look into this, all these points which I have put here, whether the patient is having fever, whether patient is having hyper or hypokalemia, or hyper or hyperglycemia, hyponatremia, or intracranial hypertension and cerebral edema causing intracranial pressure, ICP we call it, intracranial pressure. These are all very important points when we put our nutrition therapy in. So we need to look into what is your patient for whom you are planning therapy involves. So vascular spasma and other things. So to go over to the very quickly, the metabolic and biochemical process also has like apoptosis, mitochondrial dysfunction, coagulation disturbances, ischemia, reperfusion, or ROS, the reactive oxygen species, or neuroinflammation, because this is involved to head trauma, or it will also involve the whole body neuroendocrine stress response. So after looking into this, we need to see what other process, stress response. So Anita has clearly explained the stress response. So it increases the stress hormone cytokine response. We know we do a interleukin IL-6 are done with the Nutrix score. So look at it. How much is the cytokine storm? How much is the nutrition aggravation is required? What is the intensity of the injury? What is the hyperglycemia status? Patient may be diabetic or patient may not be diabetic, but patient may have hyperglycemia, as all critical ill patients behave as diabetics. The changes in lactate, metabolic changes, and damage in hypothalamic region. So there are hypothalamic region damage. There is a hematoma, subdural hematoma. There is a large infarct. There is small infarct. So what are you looking at, and what you need to do it? So that is what you need to look into. So primary principles of metabolic and nutrition core, what do we see? So make proper plan for the nutrition support of patient undergoing surgery. Now this patient with a traumatic brain injury will need a surgery for whatever is the injury. Also it will be an emergency surgery, maybe 24 hours or 48 hours. You will have to plan and look into the things. Also, it is essential to understand the basic changes, as I told you, in metabolism and result of injury. So, compromised nutritional status is a risk factor for post-operative complication. Take it this as a golden statement and assess the nutritional status of these patients. For an emergency surgery, you may not have a time to build up the nutrition status, but if you know, you will know how to go about giving the nutrition therapy. So, starvation during metabolic stress or from any other injury are two different things, and physiological starvation is also different. So, surgery itself will lead to inflammation corresponding with the extent of the surgical trauma and change in metabolic response. So, to achieve appropriate healing and functional recovery for a surgical patients, okay, you need to see their nutritional status, you need to see the stress, you need to see the inflammatory response. So there may be a prolonged inflammatory response, like for TBI patient, that will go for a long time. Sometimes the doctor will themselves, will surgeon will not know whether the patient will come out within 3 months, 6 months, or 1 year. So it's a prolonged state. So the negative effect of long-term calorie and protein deficit will change your outcome of a surgical patient. This is also a very known fact. Now, the success of energy does not depend exclusively on technical surgical skills. Surgeon may be very good or surgeon may be very junior, but on metabolic interventional therapy, which takes into account the ability of the patient to carry a metabolic load and to provide appropriate nutrition support. If you provide appropriate support, the patient will be able to carry the metabolic load better. So again, it's a key aspect, that is the nutrition therapy. So this is covered by Anita, that why it is preferred, use the gut or make it work, she said very nicely. So we must make the gut work. Early enteral nutrition, all the guidelines, SPEN guidelines, the ES European, American, the Society of Critical Care, Australian, and now the Indian guidelines 2018 also says that early enteral nutrition, whether it is surgical ICU or whether it is a medical ICU. So, enteral compared to parenteral is associated with better outcomes. We all know these are the 1800 patients, both 900 patients, and it only said that there is an infection risk for both. Regardless of cancer or any underlying primary condition, there is no difference in mortality compared to enteral or parenteral. So, if need be, we can use parenteral nutrition. So the early versus delayed, again the same thing was discussed by Anita, so I will not skip this slide. So route of enteral feeding. In critically ill surgical patients, there are two routes, gastric versus transpyloric feed. Now I would like to tell you here that intragastric feeding by mouth or tube is possible in most of the patients. Okay, most post-operative patients can be taken by mouth also, can be taken as a nasogastric feed. There are some conditions where you need a small bowel feeding, like high risk of aspiration, the known gastroparesis, intolerance to gastric feeding, or repeated and increasing high gastric residues. Now, one thing, what protocol I have been following is, when I go intraoperatively, the patient to see the surgical patient going to for the surgery, what I tell the surgeon is, hello, you are taking up the patient for surgery. My humble request is, put a GT or a jejunostomy feeding tube while you are taking the patient, so that when patient comes out, I do not delay intervention, nutrition intervention. So now we have a protocol with all the surgeon. In fact, we have a regular meeting with our surgeons, and we discuss every case in the surgical meeting, what went wrong, what could have been done. So this is was made a protocol by me way back in 90s. We know that till 90s we didn't know whether we should feed surgical patients or not, or yes or no. There were no guidelines, there were no trials. But in early 90s, we established that even the surgical patients can be fed like medical patients. So this Anita said that we don't need to see whether the gut is working, whether there are bowel sounds. Keep the stetho away. No need to listen. But there are few things you must see. That is, your head should be above. You should try only continuous feeding to reduce the at a time dumping syndrome. You must use the pro-motility agent for surgical patients initially only, and you must also use the chloroxidine mouthwash twice a day. This will improve the enteral nutrition tolerance. Okay, so these are the few guidelines which are we put up in our trauma ward, our surgery ward, and even in our OT, so that sometimes patient is in the recovery room for a week. So these protocols to be followed. So next we see here, it's a blank. Okay, effect on GI function on TBI. So what is the GI function in a traumatic brain injury? So there is a corticotropin releasing factor. The vagus nerve is suppressed. Okay, so when vagus nerve is suppressed, it is difficult to feed, and that is why there is intolerance. So reduce lower esophageal sphincter. Now this is what which brings the increases your residual volume. You need to look into all these aspects. Or fasting motor pattern during feeding, like if the patient is not fed before it was NBM state and taken away for surgery, that again that is called like a starvation phase. So, like this is a study which says gastric versus transpyloric feeding in a traumatic patients. What does it say? So, both the size, the p-value, it's a very significant study that the infection rate in a transpyloric feed versus gastric feed, it's almost 50% for pneumonia, late pneumonia, and total pneumonia. And if you see the below slide, it says increased gastric residuals. So that also is almost 50% difference when you feed with as a transpyloric route or when you feed gastric. So that obviously transpyloric route is better. So therefore, jejunostomy, feeding jejunostomy is a better way when it is a traumatic brain injury, because the signaling, the brain does not signal. So that's why the gut, the stomach becomes atonic sometimes. So that's why you must feed post pyloric, transpyloric, or in jejunum. So if we see here, pre-admission is not applicable to this patient, but for when you see other surgeries, please do pre-admission workup prior at the OPD level. All the markers, your electrolyte, your hemoglobin, your anesthesia clearance, your nutrition status clearance, your SGA, you should have the grade A, or at least B is there, then go to A, C is there, then change it to B 10 days prior for an elective surgery. Okay, I'm not going to go into detail for ERAS protocol, but this is a very good protocol for surgery. If every hospital follows, no prolonged fasting, 4 hours, 6 hours, 8 hours carbohydrate loading, I think it is very, very easy for us, the dietitians, to start early feeding. since my talk is longer, I'm not going to go detail because this itself is a one talk. The 1 hour talk we can take it on eras. So I'm not going to go detail, but you must follow eras. 2006 when it started, we started in our hospital. 2006 I'm talking. See how many hours, how many years before, and now some hospitals are implementing. Again, in anastomosis, most surgeons and intensivists get afraid to feed during GI anastomosis, and that fear is totally misleading. It's not correct. We must feed. It should not be delayed when there is a GI anastomosis. To recover from the anastomosis, to for healing of anastomosis better, we must feed. So these are the SPEN guidelines for 2017. I'm not going to go into detail, but the first statement says integration of nutrition into overall management of the patient. Now it is not only nutrition, okay? We need to integrate the nutrition with overall management. That makes your medical management, your pharmacology management, your physiotherapy, your nurses management, and all other procedure related protocols. If you see all integrate it, then I think we 100% thumbs up, we achieve our goal standard, and the therapy works very well, the outcome improves. So avoidance of long period of fasting, we already see. Re-establish of oral feeding as early as possible. Not most of the longer, even major abdominal surgery like Whipples, we are starting after 4 to 5 hours oral feeding. You can see where we have come from 60s to 90s and 90s to 2020. But there are certain hospitals, certain intensivists or a surgeon, we still do not allow this. So that is the time when we as a nutritionist should intervene. So it is a metabolic control is very important of blood glucose, the maintenance of your lean body mass, your control of blood pressure, your electrolytes. You need to check these parameters on your daily round. Then reduction of factors which exhibit stress related catabolism, okay, so which will also impair GI function. So kindly keep a watch on this stress related catabolism which is ongoing. It doesn't go with 8 days, 10 days. With traumatic brain injury, it continues prolonged. So therefore you need to look into this. Then minimize time on paralytic agent, don't use much of it, or for ventilation or management in the post-operative period. Now there are some protocols some ICUs have, and we can definitely discuss. If we take rounds with surgeons and intensivists, we can minimize on these agents, which will also be a hindrance to the enteral feeding if we don't intervene. So eat early mobilization to facilitate protein synthesis and muscle function. This is what is our job. We must mobilize this so that there is a acute phase protein synthesis for first 72 hours, and after that there is no acute phase. So after 72 hours we really need to give protein synthesis, increase the protein synthesis, and also give good protein. So emphasis on protein. So guideline presents 37 recommendation. I'm not going to go into detail. Don't take me that I will speak about that. Please look into it for a clinical practice. So I go over to the next. There is a this slide is a summary of protein intake 2017 study, both of Critical Care Society and the SPEN guidelines, and a very nice study about emphasis on a protein. So when you give less protein, low protein, what happens that you are putting an independent risk to mortality. So when you are giving increasing protein, so there are different subsets of patients depending on different surgery. So there are different surgery patients where we need to give 1.2 to 2 gram protein. There are some patients you can start with 1.2, but there are no patients where you can go lower than. This is their 0.7 they have started here, and which had directly responsible to mortality. So we have to be very careful how we start, how much we start. All are blank. Okay. So patients, here another study says patients with moderate trauma. Okay, need 25 to 30 non-protein calorie per kg of body weight and 1.1 to 1.5 gram of protein to start with. So patient with severe trauma, again there are grades, trauma index, so more than 20 and severity score more than 80 or less severe with complications, the calorie needs remain the same but increase intake of protein. So you keep the calories constant and change your protein, increase your protein with your trauma index. Okay, so check what is the trauma index written by a surgeon, or if not you can ask for it. Okay, so in this perspective, immune enhancing diet with 2.2 to 2.5 gram protein per kg per body weight is enriched with L-arginine. Remember, traumatic brain injury is a strong evidence when you need to give arginine, glutamine, and omega 3 with all the nucleotides early with your enteral nutrition to have a better outcome, to reduce the inflammatory load, because this is a prolonged, and also reduce the stress. So she has already spoken the trophic feeding in the surgical ICU. So no result in ICU with a low length of stay, no difference in hospital length of stay. This is a very small patient case study, but it did give the result that there was no difference in mortality. So this is what I want to say, that the permissive underfeeding or standard enteral feeding, Anita has beautifully showed in their own hospital studies the different reasons, and this particular study also says that 40 to 60% of goal calories we should be meeting it, and a control group they made 70 to 100%. So even when you meet your 80% of goal calories, okay, so here it is like the characteristics 90% of patients were on mechanical ventilation, and in spite of that they achieved 60%, 80% or 70% of calorie goal, and there was no difference in the mortality. So this is just a word of caution that trophic may not be for every ICU population. You can't say chalo blindly uh, call has come from a ICU and I will start 10 cc, 20 cc. No, it is not for all. So in sepsis, it appears that a higher energy and protein intake is associated with improved outcomes. So when there is a sepsis, you can start with trophic feed for improved mortality. For if the patient is for fewer ventilation days, you know that the patient will wean off in 24 hours, 48 hours, 72 hours, then also you can decide whether there is a role of trophic feed or not. There may not be role of trophic feed here. When it is expected that 5 to 7 days the person is not going to tolerate en, then you start the your enteral feed with a trophic feed. Otherwise you give your good protein intake and give your protocol. We start with the regular feed 60 cc per hours, first 30 cc and 60 cc. This is again a nutrition supported surgical patient guidelines. Some recommendations are given here for chronic malnutrition, which Anita has covered for medical patients, and similarly for surgical patients. When there is a chronic malnutrition, you have to go slow. You should avoid refeeding syndrome, and you should meet your target calorie and protein goal by at least 72 hours, third day. So that is what the guideline says. You can go through it in detail with this guideline. So patients with severe and closed head injury, it says, who do not tolerate gastric feeding, as I told you, within 48 hours, we must start post-pyloric or a transpyloric feed. But there should not be this condition, should not, the situation should not arise. It is a surgical patient. Surgical patient should have either a PEG or a page or a surgical gastro or jejunostomy done while taken for surgery. So then this will not arise. But there are certain estimated protein requirement given here for severe head injury with a Glasgow coma score. Now, this is another very easy score, Glasgow Coma score. And according to the score, you can say with non pharmacologically paralyzed, 30 calories, and protein is 1.5 to 2. And this is also adjusted with the body weight. But since in today we are not adjusting with the body weight unless patient is above 30 BMI, then we are taking 11 to 19 calories per kg body weight and protein for an expected weight. That is, you take the 10% target minus and calculate, or you put it into 0.5, multiply it and take the weight for an obese patient and then give. According in the burn patient, it is for less than 20%, and 20 to 30% you must also start it. 25 to 30 calorie you must start with the initially for the feeding, and protein also 1.2 to 1.5, going up to 2 and then 2.5, and even burn patient you can go higher. So initiate, she is already covered. Initiate the feeding, initiate in the stomach, divert lower, without Ian with hemodynamic instability. This was earlier said. Now we don't need to withhold even if the patient is unstable. I had some studies, I have not put it here. You can start, but that was for a medical patient. Okay, so monitor the tolerance. She has nicely said the GRV, if it is 250 and above. So all the protocol of your ICU should have. It is 500 to stop. Okay, so this itself says that with the complications are reduced with gold feed with 89% and 83% 200 cc GRP also we can feed the patients. Okay, so nurse, there are certain ICUs, surgical ICU, where there is a protocol by the nurse. 60 cc, immediately she'll write GRV so much. So she will already withhold the feeding without anybody's order. So this should be discouraged. Okay, so volume and GRV, keep it to 500, or even if you keep it to 250 cc, I think you will be able to feed almost all the patients in the surgical ICU. So formula selection is of course with your function of the gut. Standard polymeric formula to be started, it says, but because it is a surgery, we do start with semi-elemental or a peptide based formula. Okay, but each individual should be evaluated for surgical or trauma condition. As we saw, what is all involved in the patient, whether you need to have a hyperglycemia control, whether you need to have a hyponatremia control, or whether you have to control the hypotension. So after considering all, you select your formula and you can start slowly. So gut dysfunction is there, there is diarrhea. A diarrhea may not be because of the formula. 90% it is not because of the formula. So look into other causes. Always the nurses and the intensivists and the surgeon will blame the feed for diarrhea, but that is not the cause. Okay, so small peptide MCT you can add for direct uptake, and semi-elemental formula. Prebiotic is a small fiber, you can use it if indicated. There is a guideline for a medical ICU, but surgically, because sometimes it will irritate. So mixed fiber formula, avoid. Use only soluble fiber, so to avoid the mechanical irritation. Then obesity class 2 and 3, you can give good protein and low calorie, like 10, start from 10 calorie per kg of body weight, or up to go up to 14 calories kg of body weight, present body weight. Cannot recommend routine certain formula like organ failure formulas, or rarely use hepatic formula because it will be low in protein. Some will be very high in sucrose, which we don't want in an ICU. So that is again a wrong choice. And renal failure, again we don't need a low protein formula, so you can use a standard formula. Am I very fast? This is a very important aspect, magnesium, for your traumatic brain injury. So important role in brain functioning. In normal condition, magnesium will inhibit the action of the excitatory neurotransmitter glutamate. It blocks this brain barrier neurotransmitter. So therefore they said it should not be given. The current research is say that magnesium will relax the vascular smooth muscle, resulting vasodilation and increase central blood flow in TBI patients. So very important to give good magnesium. Plus if they are mechanically ventilated, we again need to give good magnesium for your activation of your thoracic muscles. So recommended dietary allowance for magnesium is 80 gram per day for children between ages to 1 to 3, 420 milligram for male over 30 years, and 320 for the female over 30 years. So magnesium therapies failed in recent clinical trials of trauma because of an intact blood-brain barrier at the time of administration, reducing central penetration. Under such condition, magnesium peripheral effect on cardiovascular parameter may dominate over the central and potentially neuroprotective. So it will help. Initially, it might show that it is a barrier, but then initially, if it is a potentially neuroprotective magnesium. So you can give even earlier. In my practice, we were not giving more than 200 milligram of magnesium. We are calculating, because for comatose patient, if you give magnesium more, they will still go into the deeper sleep. So therefore we were reducing the magnesium. Now magnesium is an essential nutrient that serves as a cofactor for more than 300 enzymes. We know this very well. So immunonutrition, yes. Yes, a very big yes for surgical ICU. Okay, arginine, fish oil formula, glutamine formula. The study says infection reduces to 41% and length of stay also reduces. This is the study done. Here again, the study says effect of immunonutrition on biomarkers in traumatic brain injury patient in Malaysia. This was a 2017 study. It said that IL-6 levels were significantly reduced, whereas glutathione levels were significantly higher. We all know that glutathione is a potent antioxidant which we require for trauma, also for cardiovascular injury. Okay, so the supplement glutamine, arginine, omega-3 fatty acids in immunonutrition, and so this study confirmed it, and therefore now for surgery we are using immunotherapy. This is again the study which says early PN, early EN, and prokinetic and supplemental, the protocol. So, how you must start early enteral nutrition. If it is not adequate, add supplemental PN. Okay, for a traumatic brain injury, if you're not able to meet the target goal, then you add the your prokinetic to improve your tolerance, and then you add the supplemental parenteral. If you want, you can increase the parenteral to meet the deficit in enteral nutrition to have a better outcome. So this is also a good study which we see here. So next it says there fiber formula I've already covered. So don't use the insoluble fiber. Always use only the soluble fiber. Inconsistent data is there, but high risk for ischemia, gut ischemia. Then you please do not add fiber. That is why we need to see what is involved in each individual before we add or subtract any therapy. Again, adjunct therapy, soluble fiber, as I have spoken, probiotic. Judicious use of probiotics should not be done. RCTs have shown the safety and benefit, but routinely we should not use for general patients. Surgical patients were needed because the gut microbiome is changed because of the trauma, because of the starvation, because of the pathogens, the infections, the inflammation, so many reasons. So that's why we should be using. But medical ICU, it says not to use the your glutamine. So parental nutrition, I have already spoken. Withhold PN in low risk. This is again a study which says initiate exclusive PN if you think that you are prophylactic dose of PN. If you see 7 days you are not able to feed enterally, then you start PN first. But if you see that you can start in 72 hours, then you can wait and start EN first. So this is again the study says that maximize efficacy of PN if needed. So again, in management if ICU, it says how to go about administration of PN. So 25 calories the same. Protein as amino acids should be 1.2 only, not more. Fat should be also 30%, and carbohydrate should be low, like 3 to 5 gram per kg of body weight. We need to calculate this to before we infuse dextrose to these patients. So those using surgical patients, we need to re-evaluate. There are different studies, and it is detrimental for surgical patients. So recent data says that PN may not be bad. If you will need to use it, general surgery, use early PN in those predicted to have EN tolerance. In our hospital, we have even started using preoperatively PN when it is a undernourished patient, so that the outcomes improve. So you can discuss with the surgeon, you can read the paper studies and start both PN and EN in according to the need of the individual patient. So glutamine is, yes, already fallen from the medical patients, not to use for a medical patient, but your surgical patient, it is proven that we should be using it. So dose of glutamine, we have already said that it should be zero point 0.5 to zero point 0.6 gram per kg of body weight. If you are not giving that much, please don't give it. There is no benefit if you are not giving, if you are giving less than 20 gram. Because mostly, suppose you take 60 kg reference main, 6 5 are 30. So if you are not giving one per kg body weight 30 gram, then there is no point. So you must be calculating and giving it. So subset of surgical patient, we have already seen that we must use early immunonutrition. Okay, burn patients is again, it is you indirect calorimetry. We are not using now Curry formula or anything. Indirect calorimeter is the gold standard, and then calculating with the body surface total burn surface area. So post operative, you can start with the regular diet. No need to start with clear liquids. Most people, this is a protocol. Patient has been eating till yesterday. Today, emergency surgery, liquid diet. There are certain patients who don't require liquid diets to start with. You can start with the regular formula, and you can switch on to early soft semi-solid formulas also. So you must see the details very carefully and start the formula. I've already spoken glutamine to be given. No convincing evidence to recommend in use of enteral glutamine. This is a parental glutamine study. So they say you must give parental glutamine and not enteral glutamine, because parental will not degradation, like glutamine will not become glutamic acid like in enteral it will become. So use the parental glutamine, like dipeptides you can use. Arginine I already showed. It says the role of arginine allowing trauma and blood loss. Mandatory. This study, it was 2007. But then if you give arginine and along with your other immunonutrition, you will not be harming the patient for surgical. Omega 3 also mandatory. See, this Heller et al. Says 53, 600 patients they studied, and they gave all 23 studies involving 1500 patients were analyzed, and no significant difference in mortality was found. But omega 3 enriched emulsion had a strong reduction in infection rate and length of stay and in the hospital overall days. So the recovery days. So that's why we need to add omega 3. So this is what how it goes for route after severe TBI. The dark line is parental nutrition and the light line is the enteral nutrition. See the parental nutrition, you can go higher, then you can reduce it and then become flat simultaneously with the entry. You start with the lower dose, then reach it maximum dose, then come down as a plateau and go simultaneously for 175 days of post TBI, because this is a prolonged injury. So we need to be monitoring it very carefully. Again, the status is important. Malnutrition is there in 68% of the TBI patients are malnourished because the people are scared, intensivists, anesthetists, nutritionists to feed this patient because that is a very slow recovery and a long term. They may have some infirmities, they may have some paralysis, quadriplegia, or they may have dysphagia. All of them will have a dysphagia. Okay. So effects on GI, I think my time is over. I will go quickly. Function in TBI, the releasing factor, the vagal nerve. Okay. So this is what we are constantly misled by the ease with which our mind fall into the ruts of one or two experiences. So we should not be misled by what we are, and we should be seeing the circumstances and doing it. I think I have done it. Because of no time, I will not take the case study which is there in another presentation. But that was a TBI case, and the doctor said that there will be no entrance. But then I went and spoke to the neurosurgeon, and I told him why we have kept the patient NBN. So, yeah, just one case I am talking. Hello.
Okay. Yes, 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 please.
This TBI case recently we had. So that
Okay.
patient was a young patient, 38 years old.
Hello.
Something disturbance.
If you have, I mean, if you can present one case study, maybe in 5 to 7 minutes, Miss Madam Slomi, if you have, I mean, ready with it.
Can I share then my slides?
I think
Sudarshan?
Anita ma'am, are you okay with it?
Yeah, I'm okay.
Okay, maybe just 5 to 10 minutes. Slomi ma'am, can you share?
Yeah,
Will you be able to?
Yeah, I think so. I'll just show the case. I think it didn't come in this presentation.
Yeah, yeah. Otherwise, I mean, thank you so much, Slomi ma'am. We are waiting for your slides. So, very crisp, very articulate, knowledgeable presentation, and nicely explained about TBI, the metabolic processes involved, ISPEN guidelines, immunonutrition, magnesium, role of magnesium, glutamine. So, very, very nicely explained. I am so thankful to you that you have spared your valuable time. And with thank you so much to Anita madam also.
Yeah, both
So,
ICUs are a little
yeah,
different.
but
Yeah,
she has covered it very nicely.
we think it's critical care, but yes, surgical
But
era,
yeah, yeah.
everything is different.
So I think both the concepts must be clear to all the
Oh, yeah.
participants,
Medical and surgical is different.
medical and surgical aspects. Yeah.
I don't think I'm allowed to share the slides here.
Okay, okay. No issues, ma'am. No issues. No
I will
problem.
have to. I will have to give it to her.
Just verbally tell them what it was all
Ah,
about.
Yeah. So this was a case with a 38-year-old TBI patient, and the doctor said that very poor prognosis, and they were put the patient NBN.
okay.
So when I went to see the patient in the morning, and I said that as per protocol, we put 24 hours post surgery, patient will be put on ventilator. So the patient was put on a ventilator, and then the next day also they had continued the ventilation. So then the surgeon, I said I would like to speak to the surgeon. So he said, "Ma'am, what you want to do? Prognosis is very poor, and how are we going to do?" I said, "See, you cannot put patient on. I mean, patient without feeding when you are expecting to put again on the ventilator." So patient was extubated, and we started immunonutrition on day one. You won't believe patient came out of ICU within 7 days. And
Yeah,
the
that's great.
eighth day, patient was eighth day given semi-solid soft diet
Wow.
with a severe thalamic infarct.
Okay.
Thalamic
Okay.
infarct, which is
Re-
generally not
Not
possible. Yeah,
yes,
not
yes.
possible.
So if
And
you speak confidently to the doctors, you can
yeah,
mention that why
exactly.
really for the benefit of the patients.
Yes,
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 exactly. So
definitely.
yesterday I saw the photo of the patient. I asked for it. I couldn't put it in the slide. But then he is now sitting up and eating on his own. Only there is some verbal
Okay.
deformity. Yeah. So
Okay. Okay.
It is now
So
almost
nutrition really can play a major role.
yes.
Yes, all of them.
Yeah.
So we'll go to
So
the questions. I think there were
yeah,
two questions you made.
I Anita madam, can you see some of the questions, or should I mean ask?
Yeah, I've seen one which says if you can't take weights, what do we do?
Yeah,
So
yeah.
it's very simple. It's there also for in I think the form of mask where you take the length from here to the mid here, right? And
Allah ne.
once you got this, yeah, the Allah, then you can call, and there's a table there which gives you the correlating height for men and women. So
Okay,
it's very easily done, and you do the MUAC here. So if you do the MUAC, there is a corresponding BMI to calculate. So of course, it's not very accurate, but you'll have a rough guideline on how to calculate the BMI, and you can get the height. So,
okay,
but otherwise, you can also ask the patients what has been the usual weight. May not be accurate because most of them normally don't even weigh themselves. We had a patient who told us that he's 90 kilos, and we have weighing beds. So in ICU, we weigh our patients every
okay.
week. So when we weighed them, he was 70. I said he's lost 20 kgs. Then I realized that patient had just, said something. The attendant had said something on admission. So it became a big issue for us, that within 1 week the patient had lost weight. So that was not accurate. So these are approximate, but yes, a good thing to start on, and you're not doing a blind calculation. So definitely you can do it, and it's all there in the must-ka form.
Yeah,
And I think there was one question on Apache and Nutrix
yeah,
score. Yeah.
yeah.
So
Somebody asked about the explain how to use this course
yeah,
and to explain these.
it's on there. As I said, you can't do it without the medical
Yes.
help. It's a very long form. And the Nutrix score takes into consideration all the 6 organs: respiratory, coagulation, hepatic, cardiac, and the cardiovascular, the Glasgow scores. So, all those are taken, which is a separate form. So before you come to this, you have to do the SOFA score separately. Then you have to do the Apache score separately, which is another form. So that then you combine into the Nutrix score. So it's a little long. So only mostly people are doing it when they're doing a research. But
Okay.
as an everyday schedule, I don't think many hospitals are doing it. But some good hospitals have adopted it in the ICU scenario. But it's all there, girls, on the forms to take down. It takes the parameters into account, the blood parameters, the oxygenation, the lactate levels. So all those you will not be able to do. So and each one has a different scoring, and there is even a score for plus 70 plus. So
So,
it's just there with the doctors to do it for you. So once you
Anita, there
get
is
that,
one more question coming.
yeah.
Which weight to consider, ideal body weight or actual body weight for non-obese when calculating energy and protein requirements?
So that's sorry, I didn't see it. What is it?
Is just some which weight to consider, whether ideal body weight or the actual body weight for non-obese?
No, then you take the actual body weight.
Actual.
Then you take the
It
actual
has to be actual body weight. Yes,
because otherwise he'll be malnourished.
we
So we
cannot
take
be
the
here.
actual. Only
Yeah,
if he's morbidly obese, you can't feed him. If he's 100 kilo, you can't give him 3,000 calories. So
yeah.
then,
It
then
has
there's
to be.
another system where you do the adjusted body weight, where you do minus 0.5. But this is a very simple thing. What I showed you, do 20 calories or
And
do, so calculate like that.
so one question from Mr. Rahul Kumar Pandey. He's asking, in jejnotomy feed or nasovaginal feeding, what is the maximum volume of feed per hour which can be given?
In fact, both the feeds, the tubes are small, so you can feed a larger volume also. But we follow the protocol 30 cc per hour to start with. When we go to 60 cc, 100 cc, then as per tolerance, the volume is increased. In fact, you can use bolus feeding for gastro feed. Gastrostomy tube. So you can use even 200, 250, sometimes 300 also, depending on the tolerance of the individual.
Okay.
Always start low. Always
Yeah.
start
Yeah,
low
start
and
with the low. Yes, yes, with
with
less of volume.
your targets. Yeah.
So there is one question from one of my dietitians. She is asking, do RDA recommendations work for such patients? And we have 2010 RDAs. recommended
No.
dietary allowances. So,
But that doesn't mean we should not know. You must
yeah.
always write down RDA or the right side of the paper or a left side of the paper, and then write advised or
Okay.
estimated. And so that is, they know that you are knowing the guideline, but you are estimating for the present requirement.
Present requirement.
And for the vitamins and minerals, you'll have to take the
Yeah.
RDS.
Yeah.
Yeah.
So,
Definitely.
yeah.
Definitely.
No,
So,
if you're
if
doing this 1%, thing which is low in a particular patient, maybe it's calcium or it may be zinc or maybe something else which is worrying you, then you quickly calculate for that particular micronutrient and see if you're achieving. So if you're using a nutrition formula, you'll be able to know how much you achieved in your field and does he need a supplementation or not. But having said that, giving nutrition even these micronutrient supplements is a better way than doing these expensive tests. I think they all need it.
so, I think Anita or Salomi ma'am, anyone can ask. There is one query from my side. Is there any fluid resection to be done in patients undergoing major gastrointestinal resections? So, is there, or we can give the normal fluid requirements? Is there any fluid resection
No.
in patients undergoing major gastrointestinal resections? No,
And no restriction
no
is
Start
there.
resection.
slow. Start slow.
Okay,
Output, go on the output base. If the output
okay,
is
okay,
good, add 600 cc, you'll be safe.
okay,
There is no
okay.
need to restriction.
No, there is no need to restriction. Okay. So one question from she is asking about explanation of IRAS protocols, brief out. But I think that will not be possible. Salomi ma'am, if you can just give the brief outlines.
Actually, ERAS protocol should be followed with a team, nutrition support team, surgeon, intensivist. This is a protocol to give carbohydrate prior to the surgery, intraoperatively and postoperatively. 4 hours, 6 hours, 8 hours, loading carbohydrate. Okay, so
Okay.
there is a definite protocol, and for different surgery it is applicable. Most ofly we can do for cancer surgery, abdomen surgery, and orthopedic surgery. Are recent studies saying that the orthopedic surgeries were much beneficial because these are the surgery where the gut is functioning at the orthopedic, but there is still fasting is done before and after surgery. So you should avoid fasting, overnight fast, 12 hours fast or 8 hours fast. You must give some amount of carbohydrate,
So
20 gram, 40
is
gram,
there
80
any
gram.
study? Is there any study? They say
Lot
in
of
one of the
studies.
studies they said 800 ml the night before surgery and 400 ml of
Yes.
carbohydrate before surgery.
Yes.
Is
There
it
is,
there? And we should
that's a
follow, I think.
protocol. That is
Okay,
protocol.
that is the protocol.
So 400, 4 hours.
Before the surgery
Yes. And 8
and
hours.
800 before the
400
night
and 8
before.
hours.
Yeah,
Yeah,
yeah.
but Sunita, it should be only carbohydrate loading.
It's only
Carbohydrate.
carbohydrate.
Only
Yes,
carbohydrate.
yes.
People make a mistake of doing something else.
Yeah,
So
yeah,
Yeah.
yeah. It has to be only carbohydrate. Yes, yes.
Yes.
So one person, she is asking, ma'am, as you suggested, only 2 gram of chicken actually patient received. So which food should actually be considered other than the supplements? I think this question Anita ma'am can answer.
See,
So
like,
2 gram of chicken. Yes.
yeah, I before these supplements came, I'm talking of times when we used to
Yeah.
use a lot of curd base because
Yeah.
in a curd base you can achieve a full 8 grams of protein. But you will have some Indians telling you कि इससे खांसी हो रहा है, ये नहीं दे दो.
Yes.
And if you give milk, you will have lactose intolerance. So before these seeds came, we were using blenderized dals because at least
And
that's
chicken gruels. Chicken gruels.
chicken it doesn't go in. At least
Yeah.
the dal blends. And
Yeah.
use a lot of curd-based feeds. At least an 8 gram goes into a 250 ml of feed. So, but you can't achieve anything without the
Yes.
micronutrients happening.
I
So,
agree to her. Yeah.
I don't think you need to go back. I'm telling of times when the nutrition
Times, yes.
supplements
You
are
can
not
use milk. You can use milk, curd, soya.
Yeah, but milk,
Yeah.
Soya
These
milk.
type of.
You can use
yeah,
this.
but milk has a lot of lactose intolerance because
Yes.
they're on this much of medication. All
Yeah.
will report diarrhea. Will
Exactly.
report diarrhea if you give milk. So if you cook the milk, maybe making a thin custard, maybe because then once it's released with the cereals, then the lactose intolerance is a little better. But
Yes.
having said that, please don't do it. And if you tell the patient, it may become too thick and you'll come back with blocked tubes. So even for home, don't advise.
So please use supplements.
Supplements is better.
Yes.
So I'll take one or two questions because I know Anita madam, she didn't have her lunch. So it's
Yeah,
high time. She
nothing,
must be
nothing.
feeling hungry.
I'm getting the
So
calls
there is
from the office.
there are two questions regarding eggs. Why no for raw eggs in feeds and why raw eggs should not be given? What is the alternative?
There's
So
a
this is
research,
the last question, I think.
there's a research paper which says that it causes salmonella infection because it's raw. That's why when we cook it, then we are
Yes.
looking after that. But if the salmonella goes, then you will have more
Yeah.
problems. It's there's a paper there for you to
Micro.
download on. Yeah, don't give. I knew we all used egg flip when we were
Yeah.
small,
Yeah. Yeah.
warm milk, but it's not
But
advised.
not. It is not recommended. Yeah.
Then putting it also in the feed, but then it will coagulate. So again, not the best way to do it. So
Also it will cause biotin deficiency.
again, that's what I'm saying. Huh? Raw eggs are, yeah. There's another aspect to it.
Excessive. Bilkul.
Right?
So,
Right.
should we conclude the session?
Yeah, please. Yeah.
A very big thanks to Anita madam, for Sulomi madam. You have really taken out time for very nice, very knowledgeable, very well explained presentations. I am really thankful to you people.
Thank you, Sunita. It was nice interacting with so many people. I can see there were 300.
Yeah, more than 300. Yeah,
So
yeah.
good.
Very good.
So
Thank
let's
you.
take it way forward.
Yeah, thank you so much. Thank you.
All right.
Okay,
Bye.
okay, okay.
Thank you.